Yes, thank you very much for this important question. So indeed, there is this intriguing and disturbing observation that the frequency of type 1 diabetes is increasing, especially in early ages. So when we look at people during the whole lifetime, the incidence of type 1 diabetes is increasing a little bit, but it's especially becoming a more aggressive disease. So it seems to be now occurring frequently, even before the age of 5 years. Why is this? We don't know exactly. We have learned a lot about the pathophysiology of type 1 diabetes in recent years. We know that there is a genetic background. We know that there must be triggers in the environment, because even in identical twins, we don't have 100% presentation. And so we believe that the reason for this acceleration of type 1 diabetes is really something in our environment. What can it be? We don't know is the short answer. It can be things in our food, the fact that we, as children, become a little bit more overweight, more obese at early age. Perhaps we make the beta cell work too hard, and therefore it becomes a better prey for the immune system. We don't know. Is it toxic environments? Is it viruses? Again, the viruses have become a very popular hypothesis, especially from work in Scandinavia, where they demonstrate a very disturbing correlation between especially enteroviruses and the onset of clinical type 1 diabetes. So we are better and better understanding what type 1 diabetes is, and also we are finding biomarkers of the autoimmune process of beta cell destruction, namely antibodies in the blood that are targeting antigens, peptides from the beta cell. And so when we have antibodies in the blood of a person against beta cell antigens, we know that the immune system is attacking the beta cell. And so after a lot of work and many discussions, the whole scientific community now accepts that when you have 2 or more autoantibodies in the blood, that then actually you already have type 1 diabetes. And so now we are discussing about early stage type 1 diabetes, stage 1, when a person with perfectly normal glucose values has 2 or more types of autoantibodies. What we used to call type 1 diabetes, the clinical type 1 diabetes with symptoms like polyuria, polydipsia, that we call stage 3 type 1. And in between is stage 2 type 1, which is people with autoantibodies in the blood and dysglycemia when you do an OGTT. And so what we are now trying to do is to identify people at a much earlier stage of type 1 diabetes than what we as clinicians used to do, namely when they have polyuria, polydipsia, and unfortunately also diabetic ketoacidosis in many cases. So now we believe it is the moment to go out and screen for the presence of autoantibodies in the blood in children who have perfect normoglycemia. Now, this screening can be organized in different stages. The easiest way, if you've never done screening in your area, the easiest way to start is in family members of type 1 diabetes. So people with type 1 diabetes, their children, their little brothers and sisters, even their young parents can be screened. Why? Because they have an increased genetic risk for type 1 diabetes. And also the family already knows type 1 diabetes, so the need for communication and explanation is a little bit less than when you start in the general population. So starting by looking for autoantibodies in the blood of these family members is a good way to start screening. Now, what type of antibodies should you look for? There are 4 autoantibodies that we prioritize. First of all, antibodies against insulin itself. These antibodies are typically the first to appear in children who are on their way to clinical type 1 diabetes. So insulin antibodies, but also antibodies against GAT, glutamic acid decarboxylase, is an important antibody. That is mostly the antibody that is present most as the first antibody in adults, young adults with on their way to type 1 diabetes. So insulin, GAT,
Sure.
and then 2 more new antibodies, namely antibodies against zinc transporter number 8, ZNT8, and antibodies against a phosphatase, IA2. So if you want to screen, you need to screen for these 4 antibodies and look for people who are 2 or more autoantibody positive. If you're more ambitious, if your healthcare system wants to really do things how they should be done, you can screen the whole population. Now there we are a little bit less certain how to organize it, because it is a big deal to organize screening in a whole population. So we have still questions. What is the ideal age? How often should you rescreen people who are negative? So many questions remain, and therefore I invite you to go to the website of our big European project called identify.eu, where we explain how we are testing all of these questions, how to screen, how frequent to screen, what is the best age, etc., in different countries in Europe with all different healthcare systems. And then comes the question, of course, once you find people with antibodies, how should you follow them? How should you monitor them? And there we have now, in June, published a consensus report endorsed by ISPAT, by ESD, by ADA. It was published by Breakthrough T1D, the former JDRF, where we give advice on how to monitor people with antibodies, double antibodies or single antibodies, and how to monitor them with hemoglobin A1C, with glucose values, and eventually also with an OGTT. Because it's important when you find somebody with antibodies to do once in the beginning an OGTT. Because some people, when you find them without knowing, will already be in stage 2 with dysglycemia and eventually in stage 3. The final question is, why should you screen? At the moment, the reason to screen is to find people in pre-symptomatic phases so that we can accompany them and give them a soft landing to stage 3 T1D and prevent diabetic ketoacidosis at onset. But the second reason to screen, of course, is because disease-modifying therapies are coming in our hands, where we will be able to delay the progression of beta cell destruction. And in the United States and other countries in the world, we have now a first disease-modifying therapy, Teplizumab, an antibody against lymphocytes carrying CD3 on their surface that has been approved for use in people with stage 2 type 1 diabetes. So interesting times for type 1 diabetes.
And first, thank you for sharing us your experience and insights and great work. Actually, I think type 1 diabetes, classical diabetes in my point of view, and our registry and management study of type 1 diabetes patients across all ages, with the peak incidence occurring in the 10 to 15 age group. A recently published study in 2024 indicated that among the Western Pacific region, China had the highest annual growth rate of T1D incidence, ranging from 6.5 to 14.2%. Compared to before, I mean 2000, China has experienced the fastest increase in T1D incidence, reaching up to 2.7 times higher. As Professor Mathieu mentioned, early screening for T1D is of paramount importance. In recent years, China has made some progress in early T1D screening, such as screening high-risk populations based on T1D clinical staging. However, there is still considerable room for improvement compared to Western countries, I mean very high incidence countries like Scandinavian island, Persian island, including in terms of experience with autoantibody screening strategies and standard guidelines. So we are currently focused on enhancing the coverage of the early screening for T1D. Our efforts began with the birth cohort of infants born to mothers with T1D in our CARNATION cohort, and we have expanded to include close relatives, as Professor Mathieu mentioned, which is a T1D China registered study. Additionally, we have planned, actually are going to establish a score-based network. And next month, we will release you on score care for patients with T1D, aimed to raising awareness and laying on the groundwork for early screening initiatives within schools. So that's my view.
Congratulations. Yes, and so thank you again for referring to the monitoring guideline, because it is very important to have guidance on what to do when you find people with antibodies. So I advise you to read it, because it really gives a very nice idea on how frequently you need to monitor. I will not go into the details, but what is clear is that if you have people with 2 or more autoantibodies, especially in young ages, under the age of 3, we advise to follow hemoglobin A1c glucose levels frequently. The older the person gets when the antibodies are seen, the less frequent we advise the monitoring. And as said at the beginning, you need to do an OGTT, an oral glucose tolerance test, to stage the person, to find if the person is still in stage 1, is he in stage 2, or what we find frequently when we do population screening, is he already in stage 3 without symptoms? So screening initiatives are happening all over the world. And as I said, many areas in the world are doing family screening. So where they screen sisters and brothers and children of people with type 1, also the young parents of people with type 1, but also little nieces and little cousins, because in families you have an increased genetic risk. It's easier to organize, etc. But again, many areas in the world also do general population screening. For instance, the FRIDA project in Germany by Professor Annette Ziegler is screening with the help of pediatricians in the whole area of Bavaria, the whole population of young children. Also in Israel, for instance, they are starting to screen all 5-year-olds at the time of a vaccination. So different countries are organizing themselves in a different way. Interestingly, in Italy now, it is in the law that every child should be screened for type 1 diabetes. In the autumn, in November, they will start, again with the help of the pediatricians, to start all children in the general population for the presence of antibodies. An interesting thing I want to point to is that in other areas of the world, they are screening not only for antibodies against the beta cell, but also antibodies against thyroid, TPO, or antibodies present in gluten enteropathy. So, for instance, in Colorado, in the United States, there is the ASK program, ASK, where Professor Ruwers is screening for type 1D and for celiac disease. Whereas in Scandinavia, in Copenhagen, so Denmark and Lund, Sweden, they are screening for 3 diseases: type 1, celiac disease, and thyroid disease. So the way people are organizing themselves is very different. Again, what is important is that when you screen, you also capture the people that you find. So you need to be prepared to make a registry so that recalls can be sent for monitoring these people. And also when novel agents or trials would come to your area, that you are ready to call these people to participate in trials, not only in people with stage 3 T1D, but also in people with antibody positivity, so stage 1 or stage 2 T1D.
Actually, driven by the global momentum towards early screening, diagnosis, and treatment of type 1 diabetes, the Chinese guidelines for diagnosis and treatment of type 1 diabetes, the 2021 edition, have made clear recommendations for early screening of T1D, including regular testing of pancreatic islet antibodies in genetically susceptible individuals can identify high-risk individuals at the onset of the autoimmunity. And IAA, GADA, I2A, and zinc transporter 8 antibody are currently effective predictive and screening and diagnostic markers for the T1D, and combining testing enhances the detection rate of T1D. And the pancreatic islet and autoantibodies aid to differentiating the autoimmune T1D, particularly LADA. This guideline provides crucial guidance for early screening of T1D patients in China. And autoantibody testing is routinely used in clinical settings to screening high-risk population. Relevant studies presented at the EASD this year have once again confirmed the importance of autoantibodies in T1D screening and offered new methods or perspectives for antibody detection. For example, the poster 35, the screening and monitoring for pre-symptomatic T1D, the DiUNIO project, you may know Professor Mathieu, the type 1 diabetes, celiac disease, and autoimmune thyroid disease, collectively known as the TRADE disease, often manifest in childhood and adolescence. The preclinical stages of TRADE disease are predictable, and early autoimmune biomarkers have the potential to stratify disease risk. So this study confirms the high incidence of related autoimmune disease among the first-degree relatives, supporting the relevance of screening for multiple autoimmune disease in this population. Thus, I think this model has the potential to be implemented as a large-scale screening program for identifying high-risk individuals. Moreover, it was shown that ADAP, antibody detection aggregation PCR method, was comparable to the conventional radial immunoassays for the detection of autoantibodies associated with the trait and can be applied as a first-stage screening method. So I would like to mention the second study. It's post 113. It's islet antigen 2A autoantibody positivity increase the risk of the progression within and across established stages of type 1 diabetes. So based on studies linking IA2A autoantibody positivity to an increased risk of T1D progression, researchers explored whether this IA2A consistently identifies the high-risk individuals throughout the natural course of the autoantibody positivity. The study revealed that IA2A positivity is consistently associated with a high risk of the progression throughout the natural history of T1D development. So individuals with the isolated IA2A positivity have a high risk of the disease progression than those who meet stage 1 criteria but are IA2A negative. This suggesting they should be considered high-risk early-stage patients and receive intervention with more frequent monitoring. So these are two posters I would like to mention.
Yeah, excellent, and thank you for also going into the detail of the type of assay. And indeed, we have two big types that we are using, the ELISA and the ADAP. And it seems that the ADAP is really superior, and the people in Lund that you refer to and again presenting the data are experts. So also in Inodia, in the network, we will support some screening, and we will also use the ADAP and collaborate with the people in Lund. Different people, yeah, different people there. Yeah.
Yes. I would like someday, Professor Mathieu, you got time to visit our center, welcome you.
I will come with pleasure. Let's hope I can come when we have more disease-modifying therapies.
Yes.
Yes. So this is really a landmark that we have now, the first disease-modifying therapy. And I use this word not lightly. I really believe it modifies the disease because it's only a 12 to 14-day infusion. And it has effects, if you give it at stage 2, it has effects in delaying the progression to clinical stage 3 T1D of nearly 3 years. So this is really disease modification. So it's being used now in clinic in the United States, but also in other countries. This is now being rolled out. Also in Europe now we have compassionate use programs. It's not yet approved by EMA. It's not yet submitted to EMA. But we hope to have it in our hands soon. There will be new trials also to understand better whether we need the 14-day, because in another trial in PROTECT, in people with stage 3 T1D, they only gave 12 days, but they repeat after 6 months. So we need to understand, do we need 14 days, 12 days? Can we shorten even? Do we need to repeat? And also, and that's very close to my heart, can we predict who will respond and who will not respond? Because in animal models, but also in humans, we're now starting to understand how teplizumab works and when a person will not respond to teplizumab. So this is quite interesting, and I am sure that this will roll out more in the future. That being said, there's many other very interesting agents in the pipeline in many pharmaceutical companies. There's, for instance, a big trial now running by Sanofi where we are testing Frexalimab, an antibody against the CD40 ligand interaction. Again, a very interesting study. So I'm sure more disease-modifying therapies will come to the clinic very soon.
Yes, I agree that.
Can I just add, when it comes to teplizumab, so it is an infusion. It's until now 14-day infusion, but the side effects are extremely limited. The side effects are mainly limited to the duration of the infusion, namely because you target specific lymphocytes. These lymphocytes sometimes die and release cytokines, or get activated and release cytokines. And so that's the main symptom in few people, around 2-3% of people. You have this cytokine release syndrome, which means fever, some joint pain, but it's very easily treatable with products like paracetamol, for instance. So cytokine release syndrome, but for the rest, there were some transient liver function tests, but no long-term side effects to be noticed by teplizumab, which is important, of course, because we are treating children.
Professor Mathieu just mentioned, the progress of teplizumab, and also mentioned its limited side effects. I would like to introduce some progress of this drug in China. Actually, I put a lot of effort for this drug to China, and almost 1 year. On the June 28th this year, teplizumab was approved for early access in Hainan Boao Lecheng International Medical Tourism Pirate Zone, this very special zone, and as a clinically urgent import drug to delay the progression from stage 2 to 3 of T1D in adults and children aged 8 and above. This is, nearly good news. And in August this year, teplizumab was granted priority review status by the Center for Drug Evaluation of the National Medical Products Administration in China, entering the fast track of evaluation. This is also, very new good news. And on August 27, 2 weeks ago this year, the CDE announced that the marketing application for teplizumab had been accepted. We are now recruiting the first patient that was eligible for the treatment via the T1D China Research Study Network. So I think, a lot of things has been, we got a lot of help from the government, from the peers, and other countries, friends.
Excellent news, and I hope you continue, because again, what you said in the beginning, we always think that type 1 diabetes is more frequent in Caucasian people, which is the case, but you are many Chinese, so you have many children with type 1 diabetes.
Yes. Yeah, we are such huge population, so
and as you said, your incidence is changing.
Yes.
I think Professor Weng and myself are extremely excited because we see the light at the end of the tunnel. We are starting to dare to hope that we will prevent type 1 diabetes with agents like Teplizumab. It will not be the final solution. More will come and better versions will come. But this is a game changer. We are finally, Dr. Weng, more than 100 years after insulin, starting to hope that we will be able to stop this disease, and also being presented at ESD. If we can combine these immune modulatory agents with new islet transplantation, again, all the research ongoing on embryonic stem cell derived islets, very encouraging results. Imagine we can even hope for a cure of T1D.
Regarding the potential directions in future T1D immunotherapy, I agree with Professor Mathieu on the influence of the heterogeneity in T1D on the response to immunotherapy. I read many of your papers. Our prior research has shown that HL class 1 genes, in conjunction with the DRDQ, modulate disease risk and age of onset in Chinese patients with T1D. This paper published in WHO, as you have published many papers in that. But recently, we analyzed the single-cell RNA sequencing data from patients with newly diagnosed T1D. This analysis highlights the immunological complexities of early onset T1D, underscoring the significance of cellular dynamics and signaling pathways. So this multimodal data provide us with valuable opportunities to gain deeper insights into the immunoactivity and immunotherapy response associated with the T1D. And one more thing I would like to mention, that's so-called synergy. This is exploring the synergistic effect of beta cell regeneration and the emerging immune intervention strategies to prevent and or reverse T1D diabetes. For this project, we are investigate innovative therapies in which strategies to inhibit the immune system, which attacks insulin-producing beta cells in T1D, combined with the regenerative therapy and helps repair the damaged beta cells. At the ESD conference, one notable new drug mentioned at this conference is Diamate. This is an antigen-specific immunomodulatory therapy designed to maintain the endogenous insulin production. So this has received the orphan drug designation in the US and fast track status from the FDA for treatment of T1D across stage 1, 2, and 3. So this is why I will mention that again.
Yes, and again, thank you for pointing also to the heterogeneity, because finding these biomarkers and also the work you do will give us, the possibility to go to precision medicine and choose for individual people the best therapies, and combinations are there indeed. So thank you for mentioning that.
大家好，赛诺菲医学部为您带来2024 EASD 热点播报。本次大会以糖尿病领域最新进展为核心，通过一系列生动多样的互动环节，为与会者全面展示了糖尿病诊疗的前沿动态与知识革新。其中，1型糖尿病的预防与治疗取得了显著进展，备受关注。EASD 会议期间，特邀 EASD 主席 Chantal Mathieu 教授与安徽医科大学校长翁建平教授就 EASD 上涌现出来的1型糖尿病领域的最新进展与前沿新知 展开了一场启迪思维、精彩纷呈的对话。这场对话不仅跨越了国界，更汇聚了2位顶尖专家在一型糖尿病领域的深厚造诣与独到见解，为我们呈现了一系列不容错过的精彩内容。请跟随我们一睹为快。对话伊始，2位专家首先围绕一型糖尿病早期筛查展开。Mathieu 教授首先介绍了一型糖尿病的病因及机制，强调了早期筛查对一型糖尿病的管理至关重要。其后介绍了目前欧洲在一型糖尿病早期筛查方面的策略和实施情况，如大型欧洲项目 Identify 等。他强调，早期筛查的目的不仅在于及时发现患者并帮助其平稳过渡到临床阶段，还在于利用现有的疾病修饰疗法来延缓贝塔细胞的破坏。例如抗 CD3 单克隆抗体 Teplizumab 可在一定程度上延缓2期患者向3期的进展，为一型糖尿病患者带来新希望。翁建平教授则分享了目前中国一型糖尿病的管理现状，特别是在早期筛查方面的现状和挑战。近年来，中国在早期筛查方面也取得了一定进展，例如针对基于临床分期的高危人群筛查等，但仍有较大改善空间。当前工作重点是扩大早期筛查的覆盖面，如从 CARNATION 队列中患有一型糖尿病的母亲所生婴儿的出生队列开始，随后扩大到中国一型糖尿病登记研究中的近亲。此外，还计划建立一个以学校为基础的网络，同时计划下个月发布一型糖尿病患者学校护理手册，旨在提高学校对该病的认识，并为早期筛查奠定基础。随后2位教授分别从人群到方法，细数了本次 EASD 亮相的一型糖尿病早期筛查重要进展。Mathieu 教授分享了一型糖尿病筛查人群方面的重要进展，并指出 JDRF 国际共识早期一型糖尿病监测指导为筛查后的高危一型糖尿病人群管理提供了重要指导。本次 EASD 大会围绕筛查对象的拓展，全球范围内正积极开展多种形式的筛查活动，部分国家和地区已将筛查范围扩大至一般人群。筛查内容的多样化也是当前的一大趋势。除了针对胰岛自身抗体的常规筛查外，部分地区还同时检测甲状腺抗体及与乳糜泻相关的抗体。此外，建立一个完善的登记系统至关重要。随后，翁建平教授介绍了本届 EASD 大会在一型糖尿病早期筛查方法方面的新进展。本次 EASD 公布的相关研究再次证实自身抗体在一型糖尿病筛查中的重要性，并提供了一些抗体检测的新方法或新视角，如症状前一型糖尿病的筛查和监测项目，以及蛋白酪氨酸磷酸酶2自身抗体阳性会增加一型糖尿病既定阶段内和跨阶段进展的风险。第3部分，2位教授主要聚焦了创新治疗方案及一型糖尿病免疫治疗突破性疗法 Teplizumab。Mathieu 教授首先介绍了 CD3 单抗 Teplizumab 在全球的进展情况。Teplizumab 是 FDA 批准的首个用于延缓8岁及以上2期一型糖尿病成人和儿童患者进展为3期的疾病修饰疗法，是一型糖尿病治疗领域的重大里程碑。其仅需14天的输注疗程，将2期向临床3期进展的时间延缓了近3年。其副作用相对有限且可控，主要集中在输注期间，表现为少数患者可能出现细胞因子释放综合征，可通过非甾体抗炎药来有效缓解。随着科学研究的不断深入，相信将有更多创新的疾病修饰疗法进入临床。此外，赛诺菲正在探索一种新型的第2代抗 CD40L 单抗在一型糖尿病治疗中的潜力。随后，翁教授详细阐述了 Teplizumab 替利珠单抗在中国的进展情况。2024年6月28日，替利珠单抗获批先行先试，落地海南博鳌乐城国际医疗旅游先行区。2024年8月，替利珠单抗被中国国家药监局药品审评中心正式授予优先审评资格。2024年8月27日 ，CDE 官网公示替利珠单抗注射液的上市申请获得受理。目前，翁教授团队正在通过中国一型糖尿病注册研究网络，积极招募首位符合治疗条件的患者，力求在确保安全有效的前提下，尽快将这一创新疗法惠及更多中国患者。最后，2位专家探讨了替利珠单抗在一型糖尿病治疗中的应用前景，以及未来在一型糖尿病免疫治疗领域还有哪些值得探索的方向。Mathieu 教授首先指出，替利珠单抗在一型糖尿病治疗中的应用前景令人振奋，已凭借其独特疗效，成为改写治疗格局的关键力量。此外，免疫调节剂与胰岛移植的联合疗法、胚胎干细胞衍生胰岛的研究，都展示了光明的前景。随后，翁教授介绍了团队在一型糖尿病抑制性方面的研究进展。 通过单细胞 RNA 测序技术，揭示了细胞动力学与信号通路在疾病进程中的关键作用。信号区项目聚焦于贝塔细胞再生与免疫干预策略的协同作用，旨在通过创新疗法抑制免疫系统对贝塔细胞的攻击，并结合再生疗法修复受损细胞，从而实现对1型糖尿病的预防或逆转。此外，本届 EASD 大会上也提到了治疗1型糖尿病的新药，例如一种抗原特异性免疫调节疗法 ADAP， 用于维持内源性胰岛素的产生，为患者带来了新的希望。随着研究的不断深入和技术的持续进步，我们终将能够跨越重重障碍，为1型糖尿病患者带来更加光明和健康的未来。以上是本次 EASD 报道的内容，谢谢您的关注。